and it is presented by Joan Arenillas, who is the director of the stroke program at the Hospital Universitario of Valladolid in Spain. Please. And we have Marius too. Marius.
Yes.
Thanks.
Thank you very much, Mr. Chairperson. It's a pleasure to be here. First of all, we'd like to thank the ESO Guideline Committee for choosing us, for the trust to develop this guideline, and also for the help we got from the ESO office throughout the process, from Sabrina, Yvonne, Lucia also, and also for your mentoring, and for the reviewers who did a great job criticizing the difficult guideline that we have. So, and first of all, also, I would like to, of course, mention our disclosures. Some of them are intellectual, related to grants that we both got, and other members of the group, and also related to disclosures related to the industry. So first of all, it's been a pleasure to work together with this tremendous talented work of people, and it's been really, really very, very pleasant. And also to co-chair the guideline with Marius, we put together a multidisciplinary team integrating not only neurologists, but neurointerventionalists and neuroradiologists, of course, and epidemiologists. So I hope you like the final result of our work. So why a guideline in intracranial atherosclerosis? First of all, we go through a little bit of definitions, and as you see, we try to cover the whole spectrum of the disease in this guideline, not only intracranial stenosis, so the most advanced stage of the disease, but we try to cover all the spectrum from non-stenotic ICAD. We reserve the term intracranial atherostenosis for those patients having a greater than 50% luminal narrowing, and high-grade stenosis is reserved for greater than 670, showing signs of hemodynamic compromise that can be detected as a significant reduction of anterograde flow in the downstream arterial territory that you can find in the CT perfusion or perfusion imaging, or even in transcranial Doppler ultrasound. So ICAD is a very important, so major cause of ischemic stroke worldwide. And this is so because the distribution of ICAD is very prevalent in patients of Asian ancestry, being at the major cause of stroke in those patients. Also very important in patients of Hispanic and African ancestry, but also it is important as a cause of stroke in Caucasians, being responsible for up to 10% of all ischemic stroke in our setting, and it's becoming more and more important also in the non-stenotic phase, which is more prevalent also in Caucasians. And why? Because it is burdened with a high risk for recurrent stroke despite best medical therapy available. And there are many, 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 as you will see, many open questions in this field. So we will focus in 3 different patient populations in this guideline. First of all, we wanted to ask ourselves a couple of clinical questions regarding the asymptomatic phase of the disease. Is it reasonable? Do we need to look for that? Because we now have tools to look at the vessels non-invasively, many. And what do we do if we find an asymptomatic intracranial stenosis or intracranial signs of intracranial atherosclerosis? Like here you can see more and more intracranial artery calcifications. What is the meaning of that that we can see in normal non-contrast CT? The second would be what to do in our days in the endovascular era. We are seeing more and more intracranial atherosclerosis presenting acutely, so large vessel artery occlusion that is due to a complication of our intracranial athero plaque, and we wanted to dig into this clinical problem because these thrombectomies are the most, probably one of the trickiest, one of the most refractory to treatment. And the third subset of PICO questions is related, this is the most conventional approach to the disease, is secondary prevention. What do we do? How do we manage patients with asymptomatic intracranial stenosis? So let's begin with the first group of PICO questions that make reference to primary prevention of ICAD. And the question, the first one is, in adult stroke-free subjects, is screening compared to no-screening for intracranial atherosclerosis beneficial for the prevention of MACE, including ischemic stroke? As we expected, we did not find clinical trials randomizing screening versus no-screening, so there is no evidence-based recommendation available. So the answer is uncertain, as you can see here. But we did find in the additional information section in this PICO, you can find some population-based studies showing that when you find intracranial atherosclerosis in asymptomatic patients, either with transcranial Doppler ultrasound or either as an intracranial calcification, this means that this person has an significantly increased risk of further stroke and also further other major vascular events and mortality as well. So it is our consensus statement for this PICO is to identify asymptomatic intracranial atherosclerosis as a very high vascular risk subgroup, but we don't have any recommendation regarding screening or not. So screening, we suggest, should not be performed as a primary prevention strategy. But remember, when you find calcifications, strong signs of intracranial carotid calcification, think this patient has intracranial athero and it is burdened with high recurrent stroke. We know intracranial coronary calcium is a very well-known risk factor that's used in the clinical practice, but we tend to neglect what we see intracranial calcification. So I think it must be worth looking at it in the future also. The second question is when we find an asymptomatic intracranial stenosis, what do we do with it? Do we have to give antiplatelet to the patient? So is antiplatelet treatment compared with non-antiplatelet treatment able to lower the risk of MACE, including ischemic stroke? And here, likewise, we were not able to find evidence-based literature trying to answer this question, so we cannot make a recommendation regarding antiplatelet therapy. There we need a consensus. As you see here, there's almost a draw, 7 agree, 5 disagree of the experts. So the major opinion by little is that antiplatelet should be given after appropriate assessment of the benefit-risk profile on an individual basis. And we suggest some factors that may favor the decision to give antiplatelets, such as high or very high vascular risk, comorbidities, presence of severe or multiple intracranial stenosis, those patients who show progression of intracranial atherosclerosis, and also those patients showing covert infarctions within the territory of the stenosed artery, as would be factors favoring the treatment decision, and also, of course, to consider those factors related to intracranial or systemic bleeding against the therapy. And then we move to the second block, which is going to be presented by Marius.
Yeah. Hello from my side. Thank you again, ESO, for the invitation to co-chair this guideline, and thank you to our team, which did a magnificent job. The next point is about ICAD-related LVO and the hyperacute management, and we tried to define the ICAD-related LVOs. So one point would be absence of atrial fibrillation, second would be absence of CT hyperden sign or MR susceptibility sign, watershed infarction already on native CT, a truncal type of occlusion, a residual stenosis on DSA when a stent retriever is open or after 3 stent retriever passes, and the last point to identify those ICAD-related LVOs would be an early reocclusion. And again, there is no guarantee, but those are the signs that we used and that we use in daily practice to actually be able and identify those ICAD-related LVOs. Here is an example where you can see the early reocclusion of this inferior M2 trunk in the right side after a stent retriever maneuver. So this would be a typical case. And the PICO question that we formulated was, in patients undergoing mechanical thrombectomy for acute ischemic stroke due to ICAD-related LVO, does infusion of GP2B3A inhibitors after initial mechanical thrombectomy as compared to standard of care improve functional outcome? And as with the other questions, and also in the questions we saw before, we see that we don't have really much evidence, no randomized trials, so the quality of evidence is very low. And what we can say from the retrospective studies that we found is that we have unclear patient selection criteria, a high heterogeneity, and very large confidence intervals. So our expert consensus statement is that this can be a rescue strategy, but again, we have to be cautious, and the voting was 10-2, so it's a pretty strong consensus. But again, from our point of view, from my point of view also as the neurointerventionalist in the group, we need trials showing that this is an effective and safe strategy. What about the next PICO? In patients undergoing mechanical thrombectomy for acute ischemic stroke due to ICAD-related LVO, does angioplasty and/or stenting plus best medical treatment after initial mechanical thrombectomy improve functional outcome? And as expected, also here the quality of evidence is very low. Our evidence-based recommendation is that we suggest enrolling patients in a dedicated randomized trial, and I hope that we will start those trials in the next few years, because at the moment answering this question and if it improves functional outcome, it remains unknown. The expert consensus was that we suggest that if inclusion in a trial is not possible, angioplasty and/or stenting may be used as a rescue therapy after unsuccessful mechanical thrombectomy. And although this suggestion needs to be considered with caution, since the referred studies with angioplasty and/or stenting were focused mainly on Asian patients, and the results might not necessarily be generalizable to other populations or to European populations. Okay, so we move on to the next. Okay.
So thank you, Marius. Now, one question related to the specific for this subgroup. We didn't want to overlap with other ESO guidelines, so we have the ESO BP guideline. But this question, particular question, what to do specifically in front of clinical deterioration that is caused by hemodynamic compromise in very tight high-grade stenosis, is permissive of or induce hypertension? Does it have a role compared to conventional blood pressure management during the acute phase in order to improve outcome? And here, the evidence-based recommendation is again not based in any clinical trial directly addressing this question. We found one clinical trial randomizing patients to 120 versus 140, but patients were included from the day 7 after onset, so it may well not be responding our question. So we had to go to an expert consensus, and also in order to be aligned with ESO BP guidelines, we only consider this induced hypertension as a rescue therapy only after other more conservative measures like withholding BP, lowering drugs, or fluid therapy or position therapy have been tried and do not work. 8-4. And then we move in the more typical secondary prevention PICOs. PICOs 6 and 7 are related to the antithrombotic regime for these patients. First question is related to anticoagulations versus antiplatelets. And in patients with an ischemic stroke or TIA related to a high-grade stenosis related to ICAD, and without any formal indication for anticoagulation, so excluding AFib patients and so on. Does anticoagulant therapy as compared to antiplatelet therapy improve outcome? Here we have evidence to answer this question. We have randomized clinical trials. We have the WOSIT trial, and we have the EVASIS trial was performed in Spain some years ago. And the evidence is the recommendation is strong against anticoagulant because in these clinical trials, it was associated with an increase in hemorrhage and an increase in mortality. So this was mainly driven by the WOSIT trial, which you may very well know. So the recommendation here, of course, is antiplatelet is the preferred antithrombotic drug of choice. But once we get to antiplatelet, what do we do? Do we advise for dual antiplatelet or single antiplatelet? Does dual antiplatelet therapy as compared to single antiplatelet therapy improve outcome? And we were surprised to see that there have not been clinical trials directly asking this question, so comparing in ICAD, symptomatic ICAD patients, comparing double versus single antiplatelet. So our evidence, of course, is indirect evidence coming from mainly from the Sampras trial. As you know, the medical arm used double antiplatelet during 90 days. But it was not studied against a single antiplatelet. It was given for all the patients. What we have is a subgroup analysis from 3 clinical trials studying double versus single antiplatelet in TIA or in minor stroke, which are the CHANCE, the THALES, and the CPSP trials, which have a subgroup of patients with intracranial atherosclerosis, and there the evidence of this subgroup analysis suggests that they should double antiplatelet reduces recurrence and improves other outcomes such as MACE and death, vascular death in this group of patients. So we come up with the recommendation that the suggestion that double antiplatelet is the preferred regimen of antiplatelet therapy, and regarding the duration of the treatment, double antiplatelet, probably influenced by the Sampras results, we prefer. I mean, there was a 12-0 votation in favor of going on up to 90 days, specifically in this subgroup of patients, without, with no evidence saying that going longer is better or worse in this subgroup of patients. Then we move to a difficult question that I leave for my colleague Marios related to endovascular therapy.
Okay, so the next PICO is related to patients with an acute ischemic stroke or transient ischemic attack related to a high-grade stenosis due to ICAD, and if angioplasty and/or stenting plus BMT, best medical treatment, as compared to best medical treatment alone, improve outcome. The quality of evidence in this question is low, but we were able to make a strong recommendation against intervention, and the evidence-based recommendation is that in patients with this kind of stenosis, we recommend against angioplasty and/or stenting added to the best medical treatment as a first-line treatment. So the first-line treatment should always be BMT, and of course, the effect is driven by the Sampras trial, and we also have data from another randomized control trials, and both trials show worse outcomes in the intervention arm. However, one thing that we should consider is that the devices change and also the techniques change, and that might offer more beneficial results in the next generation of trials. So our expert recommendation in this question is that we suggest considering endovascular treatment, angioplasty and/or stenting as a rescue therapy in selected patients with symptomatic high-grade ICAS after clinical recurrence, and the voting was here 11-1. The next question is also related to neurointerventions. So in patients with a ischemic stroke or TIA related to a high-grade stenosis due to ICAD, do any neurosurgical intervention plus BMT compared to BMT alone improve outcome? So we are talking about open surgery in this PICO. And again, quality of evidence low. The recommendation was strong against the intervention, and again, in this group of patients, we recommend against neurosurgical procedures. There is one randomized controlled trial, and it was published a lot of years ago, but the major stroke incidence was higher in the intervention arm, and the mortality was higher in the intervention arm, in the surgical arm at the end of the study. So, of course, the effects of EDAS are unclear, and preliminary studies suggest that it might have beneficial effects. Again, the quality of data is low as patients were not randomized and compared to historical data. That leads us to the next PICO. And
yes, we're coming to an end. Final PICOs, this one, we wanted this to be in the guideline, just to make raise awareness of this treatment, which is the remote ischemic preconditioning. There are 2 small clinical trials, randomized clinical trials, which were deemed to have a high risk of bias, so the quality of the evidence is low, but they were no signs of harm in these patients, and the first results are promising for this therapy, so we may need larger clinical trials to prove it is easy therapy for the patients that can be performed by them at home, is promising and needs to be tested. And the last PICO is, in order not to overlap with the previous speaker, is some specific point regarding secondary management of risk factors in this type of patients. The concept of aggressive vascular risk factor control, one of the first times that was used was after the Sampris trials results were published, because there they used this intervent modified lifestyle program with a tight risk factor control, which may have contributed significantly to the results that we saw in Sampris. So after this trial, at least we wanted to be in this concept of aggressive risk factor management to be in the guideline. We suggest that is favorable, and specifically to include lifestyle changes, because it was physical activity that seemed to work the best for the patients with ICAD in the Sampris trial. So the concept of aggressive vascular risk factor. Regarding the exact threshold for LDL management and the blood pressure, we don't know. There is only one small trial comparing 40 milligrams versus 10 milligrams atorvastatin in Japan, showing trends for benefit in the high dose, but very little evidence, of course. So the voting was anonymous, almost anonymous, in favor of this. First of all, to use the LDL 55 milligrams per deciliter, the EAS guidelines in 2019, suggesting that these patients have a very, very high risk. So we should start using even lowering more in the LDL in these patients. And regarding a BP target, we advise or we suggest to go for intense blood pressure reduction, even from the subacute phase, as some post hoc analysis from the WOSIT and from the Sampris trial suggest. So there are areas of future research in primary prevention, as we saw in acute management, as Marius suggested, and also in secondary prevention. The main line here is that we need more well-conducted randomized clinical trial to try to give a clear answer to these questions. And to conclude, first of all, we found overall paucity of data for effective treatment approaches. Second, regarding asymptomatic ICAD, it is to note that these patients have a very high risk for stroke, but we don't know how to manage them properly, so we need more research in this area. Regarding secondary prevention, antiplatelet versus anticoagulants as antithrombotic of choice for 90 days. Second, angioplasty and neurosurgical procedures, not a first-line treatment, but a rescue therapy for selected patients. Remote ischemic conditioning, promising results, need more research. And importance of lifestyle changes and aggressive risk factors control, specifically in this group of very high risk patients. And regarding hyperacute management of LVO related to ICAD, we need clinical trials in this area specifically. So thank you very much for your attention.
Thank you very much for an excellent presentation. I think we have time for 2 short questions, and the first one will be from the chat. So in the DAPT trials, the hemorrhage risk was higher than the beneficial effect from day 21 to 90. So in general, ESO guidelines suggest 21 to 30 days of DAPT after minor stroke, and the question is, why is this same time frame different in the subgroup of patients with intracranial atherosclerosis, even though this is based on the same data?
Yes, yes, you're right. So we chose those trials to fundament our recommendation in favor of dual antiplatelet. But regarding the duration of the therapy, we have a big discussion in the group, because we had the samples data, and the samples was a trial dedicated to intracranial atherosclerosis. More data coming from the samples group suggesting that these patients could benefit from even longer durations of dual antiplatelets. So in this particular group, I think, given the high risk of recurrence, it may be reasonable to stick to the samples treatment regime and go up to 90 days. Although we know that the longer you keep the double antiplatelet, the higher the risk of bleeding. So that's what we needed to vote, and it was anonymous voting here, all the group.
And now we have time for one last question from Professor Tony.
Very, very shortly, Juan. How can induce hypertension? You suggested to induce moderate hypertension in patients with high stenosis. How can we do it?
Yes, as I said, it would be like the last strategy. So first of all, withhold blood pressure and ensure good hydration, fluid therapy, head position, improve that. And if that fails, I would suggest noradrenaline or phenylephrine
Okay.
can be even easier to use in our experience.
Okay, it's quite challenging.
Yes, I would go, but we didn't give a recommendation regarding the drug that could be used.
Thank you.
Thank you.
Thank you very much. We'll now move on to the next speaker. And it is my pleasure to introduce Dr.